Thank you, Dr. Pranay, for this lucid literature of review of molecular diagnostic. Now we are moving to next session, that is neuro. I'd like to invite on stage Dr. PBN Gopal sir, head of the department Citizens Hospital, to chair the next session, and Dr. Chandana madam, head of the department Star Hospital, for next session. So to deliver the next talk, I will invite Dr. Subba Reddy sir. The topic is wake up stroke, the time for personalized decisions.
Thank you. Good afternoon. And congratulations for IICSM Hyderabad EC for setting the critic bar high. Every year we see the critic we're doing in a better way. And thank you, the scientific committee chair and co-chair, for giving me this opportunity. So I hope all of you are awake to understand about the wake up stroke. I'll be talking about wake up stroke and time for personalized interventions. We know stroke is very simple to manage. We have two drugs, one is alteplase, one is tenecteplase, and then we have two modalities, two imaging modalities, CT scan and MRI. So it is all timelines when to use these therapies and what is the evidence behind these therapies, and especially for the wake up stroke. So at the outline, I'll be talking about a little bit of stroke epidemiology, pathophysiology of wake up stroke, and what are the imaging modalities we have, and what are the management options, and then I will summarize. Every 40 seconds, one patient will get stroke in the world. And if you look at the statistics, once in 4 hours, one patient is dying. And then we know the window period is 4.5 hours. We need to do something in this 4.5 hours. And these are the statistics. And then we have the Indian statistics also. And most of the stroke deaths happen within 7 days, and it causes significant amount of disability for stroke in stroke patients. And then if you see the National Registry for Stroke, which was published in Lancet 2023, the strokes are more common in the rural population, and 70% of these patients, they die within 1 week. So wake up stroke and strokes of unknown time onset. So these two, can we put these two into one bucket, and then we say we can treat these in a similar way? So, but like there is, if you look at the pathophysiology, they're slightly different. And in wake up stroke, they follow. We all have circadian rhythms, and in the studies, in the epidemiological data, they have proven the peak is at morning 6 o'clock. 6 to 8:30 is the peak to get a stroke. And then we will look at the reasons. If you look at the reasons, there are structural problems, like the patient may be having patent foramen ovale, or the patient may be having right to left shunt, or the patient may be having obstructive sleep apnea. This again causes hypoventilation, hypoxia, and then the thrombosis that will lead to stroke. And when they wake up, they present with stroke. And if you look at the imaging modalities, we have imaging modalities like CT scan, and then we have MRI, and then we have again angio, CT angio, MR angio, and then we do neck carotid Doppler, and then we do transcranial Doppler to complete the stroke evaluation. So in a large population based study for wake up strokes, they found wake up strokes are not uncommon. We see in 14 to 15% of the stroke patients, what we get to ER are wake up strokes. And then how to manage these wake up strokes. So mainly the key is imaging and the mismatch. We have two mismatch. One is diffusion flare mismatch, and the other one is perfusion and diffusion mismatch. So when it comes to diffusion flare mismatch, if you see this MRI, so when you get a wake up stroke patient, you don't know the time of onset, and you don't know the window period, quickly do MRI. If you do diffusion weighted flare and then the GRE, it will take exactly 8 minutes. So MRI is not time taking. If you know what sequences you need to do, it will it is as quick as CT. Within 8 minutes you can finish MRI. And then if you look at this MRI, and then if you see, this is a diffusion weighted image, and then you can see the MCA infarct. In the flare, there is no hyper intensity. That means there is diffusion flare mismatch. This patient, probably the window period is less than 4.5 hours, and then we can thrombolize. And then this is again the capsuloganglionic lentiform nuclear basal ganglia infarct, and then you don't see in the flare. And then if you see in the next MRI, in the diffusion weighted images and in the flare, both you can see the hyperintensity. So this patient, the time window is more than 4.5 hours. So there's no diffusion flare mismatch, and this patient probably not a candidate for thrombolysis or any reperfusion therapy. And then again, the MR perfusion diffusion mismatch. So you can use perfusion diffusion. If you see in the diffusion, this is the core tissue, and then if you see the perfusion, this is the vulnerable tissue. This tissue will respond to the reperfusion therapies. So this is the perfusion weighted image, and you need not have MRI machine in your hospital. If you have CT, you can do CT perfusion. So Dr. Andrew Drumchik was here, I think 2 years back for a stroke conference in Hyderabad. So he's from the Alberta stroke program, and he's the one who has given aspect score for the world. And according to him, they use CT perfusion in their hospital, not MR perfusion, because the CT perfusion is also as good as MR perfusion. And then if there is a mismatch, and then if the core to penumbra ratio is high, and then we can go for reperfusion therapies. So in various studies, they have seen the like normal CT, perfusion CT, and then normal CT with CT angio, and then they have seen they use MR diffusion flare mismatch, various imaging modalities they used in most of the trials. So in this stroke editorial, the wake up stroke, what is the difference between wake up stroke and non-wake up unwitnessed stroke? They say wake up stroke, based on the pathophysiology, the prognosis is good. In non-wake up unwitnessed stroke, they live alone because of the aphasia, because of the cognitive symptoms. So they may not express, they may not reach the hospital. So in those scenarios, the prognosis is not good. But in the wake up stroke, the brain tissue is preserved. They will have very good collaterals, and the outcomes are better in wake up strokes if you manage properly these patients in your ER. So we know there are few trials, these are all sentinel trials like diffuse 3. According to diffuse 3, if you can thrombolize these patients in 6 to 16 hours, but this is highly flawed study, industry driven, and Trevo systems they used for thrombectomy. But if you look at the Dawn, they have taken patients within 24 hours after the onset of the stroke, and they used both IV thrombolysis and thrombectomy, and then they used all three systems like Trevo system, Solitaire, and Penumbra, and then the outcomes are better. And then after that, extend IA. They use tenecteplase within 24 hours. Again, the outcomes are better than alteplase. And then the wake up stroke. In the wake up stroke, again, they used MR diffusion flare mismatch, and then they have given thrombolysis, and then they have seen the better outcomes. So we know there are two drugs, and most of the recent trials, if you see, the tenecteplase has advantage over the alteplase because of, if you see the PK/PDs of both the drugs, there are definitely advantages for the tenecteplase, and we can use, because wake up stroke patients are already, you don't know the window period, you don't want to waste even 1 minute for these patients. So if you use tenecteplase, you can give a bolus. If you use alteplase, you have to give infusion over 90 minutes. So you might have seen in our hospitals, the neurologists sometimes they load tenecteplase, they go to the CT rooms, and then after the CT perfusion, they give tenecteplase there itself in the CT rooms before transferring the patient to MRI, so that you can save time, and the outcomes will be better. So again, there are two trials. One is wake up trial. That is in the wake up trial, they used again MRI based thrombolysis for all wake up strokes. And the another trial, THWAS, that is thrombolysis and acute wake up unclear onset strokes. Again, they used alteplase in these two trials because those days the tenecteplase was not so popular. They used alteplase in these two trials, and the results, in spite of not in the window period, when they used altiplase in these two trials, the MRS scores were better, and intracerebral hemorrhage, there is no difference between two groups. So again, to make our life more simple, this is one fascinating study. They used only plain CT, no advanced imaging, and they used a tenecteplase, easy to administer. It is bolus. In the twist trial, they used the imaging modality is normal CT, and the perfusion, they gave thrombolytic agent with tenecteplase, and then they found tenecteplase has more advantage, and CT is enough. If you do a CT, if there's no bleed, and then if you don't see any hypodensity, then the stroke hasn't evolved. So we can give tenecteplase for the wake-up strokes. In the twist trial, they found these two. We can use normal CT, and then we can use tenecteplase. And then they have seen in for latest trials, they have seen the efficacy and safety of tenecteplase in wake-up stroke patients, because these are all out of window period, and then you are using tenecteplase, and then they have not found any increase in intracerebral hemorrhage rates, and the outcomes are as good as altiplase, and they have not found tenecteplase is superior, but tenecteplase is safer, and then the outcomes are as good as your altiplase. So this is one very good study. They gave tenecteplase for ischemic stroke at 4.5 to 24 hours without thrombectomy. So if you are in a rural place, or if you are in a town where you don't have your hospital is not high volume center for neuro interventions, you don't have a good biplane cath lab, you don't have neuro interventionists, but you can do IV thrombolysis. In this study, which was published in New England Journal of Medicine, they gave only IV thrombolysis, and they used tenecteplase in these patients. And then most of the patients who did not undergo endovascular thrombectomy, the treatment with tenecteplase administered within 4.5 hours to 24 hours, and they have seen better MRS scores. And the tenecteplase provided disability-free recovery in this major trial. To summarize, yes, we need to, in wake-up stroke patients, we need to properly evaluate for patent foramen ovale and right to left shunts or OSA component. And imaging, you have to select properly. What imaging you have to use for these patients, either diffusion flare mismatch or perfusion diffusion mismatch, or you can use CT perfusion, and then based on this, you can thrombolyze these patients. And we can use transcranial Doppler after thrombolysis, and then you see the TB flow. And if you have transcranial Doppler, you can monitor TCD in our neurointensive care units. And one modality to prevent these wake-up strokes. So generally, when you are giving antiplatelets for these patients, instead of giving during in the morning time, if you give antiplatelet during evening time, so there is 2-3 trials showing you can the wake up strokes in these patients are less if you give antiplatelet in the evening. So that's all. Thank you.